Yeah, there we go. Without waste much time, my talk is on turning the pyramid of care. I will explain as I go why the pyramid is to be turned, but let me start with the history of obstetrics. In the beginning, obstetrics wasn't done in what the way we are doing, whether obstetrics or midwifery. It wasn't this way, the way it is now. Before, women would just get pregnant. When their pregnancy is due, they would go to midwifery homes where they would deliver. That was the setup of the most organized government of the day, which was the British government. Obstetricians will only be called if there is a problem with the delivery. There was no antenatal care then. So that John William Ballantyne, who was not really an obstetrician, was more pediatrician than obstetrician. There were no people called obstetricians. They were just physicians, but he was more linked towards, he did more work in pediatrics than he did in obstetrics. When he was the president of the Edinburgh Society of Obstetrics and Gynecology, he gave a talk to his colleagues in 1906 where he argued that it was better to check the beginnings of evils in pregnancy than to wait till an abnormal gestation had developed into a labor dangerous for infant and mother. He was advocating for early assessment of the pregnancy to his colleagues in 1906. But his colleagues nobody listened to him then, because people were saying, why should we do that? We should just go there and assist the delivery, because that was the practice of the day. So that was his argument. And people began to realize that despite all the advances that had happened then in the field of obstetrics and midwifery, the perinatal and maternal deaths remained high because the identification of the high-risk group was so difficult. So, with the evolution of time, you will see that these are our problems ourselves, where we are saying, why do mothers die? Mothers die from hemorrhage, from eclampsia, and then all the other things. But hemorrhage and eclampsia are the leading causes why women die when they decide to have babies. Why do babies die? They die because they are being born too early. They die because the placenta has failed to work well, or labor has been mismanaged. That's beta asphyxia. Or they die because no investigation of the pregnancy was done, or proper investigation. When you don't investigate pregnancy properly, how do you label the death of a baby? You call it unexplained intrauterine fetal demise. In other words, when we fail to do the proper thing, we hide behind our shadows and we just say it's unexplained. You can see that in our country, it's almost a fifth of these babies who die and we can't explain. Then they also die because there is more than one baby there. So that what it means is that having more than one baby is a pregnancy dangerous on itself. Just having more than one baby is a pregnancy dangerous. So these are the problems. And these problems have been there since the beginning of obstetrics or midwifery, because midwifery and obstetrics are one and the same thing. So because there was no antenatal care, then came this gentleman, Arthur Greenwood, who was the Minister of Health of England. He was not an obstetrician, by the way, a medical doctor, by the way. I think he was an economist or something like that. But he was not a medical doctor. But he was the Minister of Health in England. So after the protest from women were protesting because the maternal mortality was very high. The perinatal mortality was very high in those times. They were protesting, demanding antenatal care from their government, which is the government of Britain. The government didn't want. Why? Because it would increase the bill, the government bill. So they protested, some were even shot and killed in those protests where they wanted antenatal care. Until the government finally gave in, and the Minister of Health came up with this pyramid of care and said, now your protests have been heard, and now this is how we are going to assist you. We would want you to attend your first antenatal clinic at 16 weeks. To do what? There was no answer. You have to come at 16 weeks. Then after that, you come at 24, 28, 30, 32, 34, 36. Then when you are closer, make sure every week. To do what? It was not clear what to do. It was just arbitrary to say, come and have the midwives look at you. With the assumption that with that looking, they will find something. That was the plan. And this plan was adopted throughout the whole world without anyone thinking to say, why 16 weeks? Why is it a magical number? Why are we particular? Why 16 weeks? Nobody thought. And the whole world adopted this plan, including our source. This is why women come late to book. It's because of Arthur Greenwood, who told women to come at 16 weeks. And this is the antenatal care you see being practiced throughout the world until now, in our times when most countries have already changed, except us, where we are still advocating for women to come to book. And we are telling them that, look, come when your tummy is visible. Right. So, what were the problems? How did things evolve over the years? The push for antenatal, for prenatal screening. Sorry, let me. I didn't notice that. Let me hide this. Right. Yeah, there we are. So, with the evolution of screening for Down syndrome. In the 1970s, you are aware that maternal age was the marker to say you need a needle test or you don't. The moment the woman reaches the age of 35 years, they will be told that your risk for Down syndrome is high, go and have an amniocentesis. That was the policy in England in the 1970s. But people discovered that actually women who are below 35, more than 50% of Down syndrome babies occur to women who are below the age of 35. Then they got puzzled. They said, then how can we identify women to give the jab, to take the fluid? Then they came up with the serum to say, we're going to be checking the serum alpha fetal protein. If it is abnormal, we put the jab. Still, that was not good enough. The detection rate was low. They were still missing babies with Down syndrome. They went on to say, why don't we offer a triple test that involves beta HCG, the inhibin A, the estriol, to try and improve the detection rate. That was in the 80s. Slowly it didn't work until Professor Nicolaides discovered that babies with Downs are likely to have a thicker nuchal translucency if you measure that nuchal translucency between 11 and 13 weeks plus 6 days. That was in the 90s. Then the nuchal translucency became the only standard test for screening for Down syndrome in the 90s. But however, the challenge was this test had to be done before the woman could come and book at 16 weeks, which Arthur Greenwood had proposed. So there were no women to do this test on because they wouldn't come. And nobody would encourage them. The health workers would tell them, no, don't come now, come on here at 16 weeks. But they would miss the opportunity to be screened for Down syndrome using the most sensitive test of their times. So this was the dilemma now. And in the 2000s, because nuchal picked 60% of babies and missed the other 40. So they introduced now the biochemical markers to aid them to the nuchal translucency to try and increase the detection rate of babies Downs. Why Downs? Because Downs doesn't kill in 80% of the babies with Downs. They live normal life expectancy, but in England, the government looks after the weak or those who are not able to look after themselves like Downs. So the government didn't like the bill that was coming from looking after people with Downs. This is why they decided to screen and say, we're going to screen everybody. Those who are likely to have Downs, will offer them the option for termination. So that we lower the bill for looking after somebody for 60 years, because they can live up to 60 years. So this is how it evolved, right? So nowadays we are doing the fetal self-readinate test in the 2010s. This, after being frustrated that he had discovered a marker for Down syndrome, which could happen in the 12 weeks, but there were no women who were coming. He advocated for the turning of the pyramid of care. When he said, look now, guys, it is not true that you cannot predict a pregnancy which is going to have complications at 12 weeks. Because the assumption by Arthur Greenwood was to say all complications develop in the last 4 weeks of pregnancy. This is why women were asked to come every week. That was the assumption, to say in early pregnancy, you can't pick anything. So there's no need for women to come to you that early. Two, there's no need to follow up them so tight because they will all develop complications later. But that was not true. So Professor Nicolaides argued that let's turn the pyramid of care. By turning the pyramid of care, what do we mean? So what we try to teach the world then, which has been adopted in many countries now, all the developing countries have adopted this kind of pyramid. His argument was all women should come at 12 weeks and be seen and be assessed for the risk of the pregnancy. Those who are high risk, they are going to be given what we call individualized care plans. They are not going to be looked after like everybody else. They're not going to follow a national ANC protocol guideline. Because a national ANC protocol guideline is for the low risk group of women. The high risk group of women need individualized care. So that was the argument. Then those who are picked up as low risk, they should still see a specialist at 20 weeks so that they can be risk assessed again. So that the high risk group again are given individualized care plan and managed different from everybody else. And at 37 weeks, there was supposed to be another risk assessment. And at 41 weeks, they will have what you call a pre-induction or a pre-delivery assessment to see whether it is safe to induce or not. So this is what Professor Nicolaides argued for. So what should happen now in the change pyramid of care? What is it that we should do to women when they come to us? Women should book before they go beyond 13 weeks and be seen by whoever sees them, whether it be a midwife, whether it be a general practitioner, or whether it be an obstetrician. Women should book at 12 weeks. When they book at 12 weeks, they should be risk assessed. They should be risk assessed for what? First of all, we need to date them. We need to assess them for the risk of multiple pregnancy and then determine the chorionicity. You will see today, as my colleagues present, that there is chorionicity matters. You want to know, are the twins sharing the placenta or not? They need to be assessed for HIV. They need to be assessed for chromosome abnormalities such as Downs, Edwards, and Fetal. You will see, as well as my colleagues present on this, and they need to be assessed for preeclampsia. Preeclampsia is a scourge amongst our people because it's more common in Black people, and it is really ravaging both mothers and babies if you go to the big hospitals. They need to be screened for small babies. Small babies are the ones that end up as beta asphyxia. You saw the chart that they are the second leading cause after preterm birth. They need to be assessed for fetal anomalies. They need to be assessed for cardiac defects, which are the commonest congenital defects globally. They need to be assessed for preterm birth. They need to be assessed for placenta disorders. This is at 12 weeks. That is pregnancy risk assessment. Women who do not pass the 12 weeks, these women will need a specialized or subspecialized care, and they need an individual care plan, as you will see how the care plans evolve during today's presentations. When they come for second weeks, for 20 weeks, second trimester risk assessment, they again should be assessed for the risk of preeclampsia, the risk of fetal growth restriction, the risk for anomalies, the risk for cardiac defects, the risk for preterm death, and the risk for placenta disorders. When they come back at 37 weeks, they should be assessed for the risk of late onset preeclampsia. Today, we will learn that there are two kinds of preeclampsia, the early and the late onset preeclampsia. And they could both be bad, but the early is the bad one. They should be assessed for small babies, which is fetal growth restriction. They should be assessed for overgrowth. Overgrowth could be a sign that the mother has got gestational diabetes or is undiagnosed diabetes mellitus, or they are overgrowth syndromes. They should be assessed for abnormalities. They should be assessed for placenta disorders, and they should also be assessed for abnormal presentations. And when they come for the fourth risk assessment, that is at 41 weeks, those who go beyond, they should not be assessed for what you call pre-induction assessment. Pre-induction assessment, we are saying, is the baby ready for natural birth? The placenta has to be assessed for proper function. The baby has to be assessed for proper size, whether it is the right size to come out. So this is what we mean by turning the pyramid of care. The old pyramid of care, unfortunately, is outdated and it is now obsolete. It is bizarre in our times for a woman to walk and say, I'm pregnant at 20 weeks or even at 30 weeks. The trauma that this does to women who unfortunately have complicated pregnancies is unmeasurable. Picking up defects that should be picked at 12 weeks, at 35 weeks, is very traumatic to couples and to us health practitioners who pick them up. So this is why we are saying we need to turn the pyramid of care. And everybody needs to know that the pyramid of care has to turn and women have to present early. Thank you for listening.